Cape Cod Broadcasting weaves the listening environments of 99.9 WQRC, Ocean 104.7, WFCC Classical 107.5, Cape Country 104, and CapeCon.com's website experience to reflect the lifestyles of the people who live, work, and play on Cape Cod. We hope that you enjoy this podcast.
Good morning. I'm Laura Reckford, and this is Sunday Journal. I'm here in the studio with Ray Tomasi, CEO of Gosnold. Ray, welcome to the show.
Hi, Laura. Thanks for having me.
Let's start with an overview of Gosnold, which is really the premier addiction treatment facility on Cape Cod. Tell us about what Gosnold is, what you folks do there.
Well, actually we're in our 42nd year of service to the Cape and the islands, and what began as a 20-bed detoxification unit back in 1972 is now a program of 4 different inpatient locations with about 175 beds of care, 7 outpatient clinics, 5 on the Cape, 2 off Cape, a very new prevention division, a number of other services that we provide in the schools, family services. So it's what we've tried to do over the years is build a continuum of care from acute all the way through outpatient, a continuum that essentially mirrors the chronic, long-term nature of addiction and emotional mental health disorders.
Now, if patients want to get into Gosnold or family members have a family member that they want to get into the facility, what is that process?
We have an 800 number, 1-800-444-1554. It's a central intake department, so the call made there will direct the person who maybe, if they're interested in an inpatient setting, that will direct them to an intake worker. If it's an outpatient appointment, to an outpatient worker. And so the idea is to try to help folks get access to care as quickly as they can. It's the kind of condition that people generally don't do too much about until a crisis erupts or situations become very dire, and so it's very important to try to respond as quickly as possible. And we do that. We do it pretty well, but there's tremendous demand for services. And, right now we get between 700, 800, 900 calls a week. So it's a pressing issue in our community and, in the country as a whole, really.
We always hear about the shortage of beds, particularly lately, and of course you have inpatient and outpatient services, and you're talking about, I think you just said 900 calls a week. Is that what you said? An incredible number of calls. How many people can you deal with inpatient, outpatient, and in all your different facilities?
Well, to sort of put some frame around those calls are coming from all over. Certainly from the Cape, southeastern Massachusetts, other parts of Massachusetts. As we've grown, and as we've been in, venues to tell folks about what we do, there's a wider geographic span that comes to bear. Most folks who think about getting treatment for addiction think about going to a detox. That's in some ways erroneously synonymous with what it means for treatment. But a detox is essentially an emergency room for addiction. Very short stays, stabilization stays. And so what we're working very hard to do is find ways to help people avoid detox in the first place through prevention and early intervention, and then to help people who have been in treatment, who have been in hospital settings, to stay abstinent longer, to stay in recovery longer so they're not revisiting hospital stays. So I'm a little bit in the minority, I think, around in the state. I think we'd need more beds for sure, but beds and more beds, I don't believe is the answer to how we really solve the addiction problem. The addiction crisis that we have right now has spawned a lot of interest in doing something very emergent, and I'm sort of cautioning about knee-jerk responses. Yes, we need more beds so that people can get care when they need it, but we need much better extended engagement programs with patients to keep them from coming back to beds. 83% of the people who are admitted to detox units in this state have been there more than twice, more than once. Over half have been there more than 5 times. So emergency rooms are good for emergencies, but it's not the way to solve a chronic health condition.
And that's an interesting point. And so what is the typical Gosnold patient recovering from? What types of drugs are involved here? Alcohol? What are we talking about?
Well, of course, what's happened over the last – it's really the opiate crisis that we have today is about a 15 to 18-year trend that we've been seeing, a rising use of opiates and rising dependence on opiates. And so today, in that emergency room, if you will, setting of the detox, about close to 60% of the patients identify an opiate as their primary drug of dependence. And probably 60% of them point to prescription pain medication, the others to heroin. More broadly speaking, alcohol is by far the most abused drug in the country. There are about 480,000 heroin-addicted people in the country. There are 18 million alcohol-dependent people in the country.
Very interesting. Now, and you had mentioned when you were talking about Gosnold that you have a new prevention department just launched. Tell us about that and the importance of it.
Well, this is part of what we're sort of looking at this as our bookend treatments around some of the core things that we do. The bookends being what happens after you leave us, how do we stay connected with you, and on the front side of that, how can we do better to identify earlier, to do interventions earlier, to do what most people see as very rational in the treatment of other chronic illnesses. Can you identify it earlier? Can you initiate interventions or clinical treatments earlier so that people don't need to have costly stays in hospitals and do not suffer from advanced stages of the illness? And so we're working with primary care physicians in the community. We have counselors and clinical people in several primary care offices, working side by side with the medical team there, trying to do better screening. There are some very good screening instruments that can tell you whether a person has a tendency to, or whether it's a family history. That's a great indicator, really. And if we could begin to identify those things, help people understand them a little bit better, put in some cautionary interventions, maybe we don't end up with everyone waiting till the last minute to try to run to a detox. And so we're doing it in primary care offices. We're working with the community health centers. We just put a clinician in our first specialty practice, an OBGYN practice, to help intervene with young women or of childbearing age who are either pregnant or postpartum depression is another big issue. So it's really a great stress on linking more effectively with the general health care system, because this is a medical condition just as much as it has social consequences. It's really a medical condition. It needs to be treated.
Now, when we talk about prevention and then, of course, treatment, and then at the other end of the spectrum, I know you're doing some very exciting things about keeping in touch with your patients after they leave Gosnold, and how is that working, and what are some of the programs you do there?
Well, one of the things that we're doing right now is we're targeting the 18 to 28-year-old demographic, the young adults. That's the most prevalent and the most significant change that we've seen in the last few years. 34% of the patients who we admit to the detox are under 24 years old. So that's a growing concern. And what we did is we looked at about 75 of those patients. Over 90% of them who were in our program completed the program, accepted referrals to continuing counseling care, how to support a family member, yet 2.5 weeks later, 18% of them had resumed using. And so what we began to see is that we need to be much more aggressive, much more comprehensive in how we do post-inpatient follow-up care. And so we developed a program. We call it the Young Adult Opiate Program, but the core of it is that we're using what we call recovery coaches to work with individuals after they've left the program, personalized recovery coaching. We work with the family and the individual. They have a recovery coach who's in contact with them as much as possible and helps them not just get to their medical appointments and their medication appointments, but also works with them to help get re-enrolled in school, help get jobs, working in an area that we now call recovery socialization. If you're 24 years old, it's not terribly thrilling to know that, well, you have a recovery coach that's going to make sure you get to 12-step meetings, get to your doctor, get to your dentist, get to your counseling. After a while, it's like, is this it? And so the most recent addition to that program is what we call recovery socialization. So we're doing things to help people understand that life can be fulfilling. Life is not over because your addiction is being put to bed. The idea of continuing to chase after this phantom called euphoria of drug addiction, there is really no euphoria once you become addicted. It's a matter of just trying to stay alive. That there can be life after that. And so we've been on ski trips, fishing trips. I mean, we're doing all sorts of things. The good thing about that is we now have about a year's worth of experience under our belt. We're just looking at the data. I've seen the preliminary reports indicate about a 35 to 40% reduction in the use of detox services, about an 80% reduction in the use of rehab programs, inpatient rehab programs. There hasn't been, we have 65 young people in the program right now. There hasn't been one new legal offense in the entire year. That's a staggering statistic for a group that in the year prior to entering the program, I think there were 26 legal entanglements that they had, and only one admission to a hospital in the entire year. So not only is it helping individuals and families stay in remission longer, it's also helping to reduce the costly services that are associated with ERs, criminal justice costs, and inpatient hospitalization costs.
Well, it sounds like it has already. It appears to have a remarkable success rate with this problem that is really the big problem of relapse. And tell us how tough is it for people to, once they get clean, because we read in the papers how people have been in and out of treatment, how tough is it to stay off these certain drugs once you're out and about and there's social pressures and you're in the same environment? What are the issues there?
No, the issues are unique to addiction, but the issues about how a person remains in remission from a chronic illness are actually very common when compared to other chronic illnesses. And so when the research shows that in the 1 year following an acute treatment for addiction, diabetes, hypertension, or asthma, that 1 year later, about half of the people will have a recurrence of an acute episode. And I think what that essentially says addiction is pretty much the same success rate as other chronic illnesses. The difference is we don't really, as a society, see addiction as a chronic illness. We see it as a failing of character. We see it as a weakness. We see it as a series of volitional actions that people make decisions to do things themselves. And certainly there are decisions like that are made with all chronic illnesses. So the hypertensive patient who comes back to the hospital and confesses, if you will, that, well, they started smoking again, they put on 30 pounds, they're not doing the exercises. We don't say to those people, well, you're not interested in getting well, so why should we treat you? What we do is we say, okay, let's try something different. Let's try something new. Let's put you on a patch for your nicotine addiction. Addiction is a very different kind of an illness, partly because of some of the social consequences. You know, people have things taken from them. People get hurt. People get killed in accidents. And so there's this idea that people are doing things strictly because they don't care about anybody else. It's a very illuminating thing to sit down with a patient in one of our programs and hear them talk about what it's like to live with the emotional, sort of residual emotion of what happened when they had their kid in the back seat and they were driving around high, or what happened, how they feel about having cleaned out their son's college savings account to buy drugs. Those are actions that no one in their rational mind would do. And so what we have is the consequence of a brain dysregulation that occurs in some people who react to these drugs in a way that's different from other people. 90% of the people who drink do so without incident. The 10% who do are viewed as some sort of anomaly. What's wrong with you? Well, what's wrong with them mostly is that there's brain function that is not clicking, to put it simply, the way it is for other people. And so when you introduce a drug into that reward pathway, something different happens. And so neuroscience is teaching us a great deal about that. In the last 10 years have been some really groundbreaking things, not only to be able to identify specific areas of the brain that are implicated in addiction, but also to show the changes that occur in those areas when a person remains clean and sober, if you will, 6 months later, 9 months later, 1 year later. So what we say is the first year is critical. When you get to about 5 years in remission, your chances of a regression fall to under 15%. See, we see those kinds of phenomena in other illnesses, and we recognize that they're part of the chronicity of them. Cancer patients get to 5 years, and they actually change the diagnosis. They say, you're no longer in remission, you're cured. No cancer patient really believes that, and they're vigilant, and they get checkups. So there are a lot of misunderstandings about addiction, and part of it has to do with how society has viewed drugs and alcohol and how we've integrated into our life over the years. It's been a very bumpy ride over the last 100 years.
And people are looking at this these days as you say, it's a society issue and getting different parts of the community involved and working together. And so we have, for instance, the Falmouth Prevention Partnership, which Gosnold is very involved in. And tell us a little bit about that. We only have a couple minutes left.
The Falmouth Prevention Partnership has done a fabulous job. Over the last 5 years, they had a federal grant to initiate this program in the town of Falmouth, created a great steering committee, a great coalition of concerned people. We brought them into the Gosnold umbrella when the federal dollars expired, and we're using that as a model to try to help other towns and other communities develop the kinds of changes in the culture of the community about drugs and alcohol. So the partnership's been able to get things like the Drug Take Back Day. We have a sticker shot, what we call a sticker shot campaign, pre-prom seminars for parents. We call it Parents Who Host Lose the Most. And it's made an impact. Over the last 5 years, the percentage of high school kids who are underage drinking has gone down in Falmouth. It's not a big number, but if you can get that curve to bend the other way, you're doing something special. And we hope to be able to do that across Cape Cod. By the fall, we should be in 12 schools on Cape Cod with clinicians. We have clinicians in middle schools, elementary schools, high schools, very willing and supportive and collaborative school systems that are interested in trying to help young people who are troubled by this epidemic.
Such a fascinating issue and so critical on Cape Cod these days. Unfortunately, we're out of time. I've been talking to Ray Tomasi, CEO of Gosnold. I'm Laura Reckford, and this is Sunday Journal.
This podcast is a presentation of Cape Cod Broadcasting, which is solely responsible for its content. Thank you for listening. For more information, please visit us at capecodbroadcasting.com.